Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Josh Wageman is a clinical lipid specialist with multiple doctoral degrees who formerly practiced in endocrinology. His PhD work focused on cholesterol disturbances in Alzheimer's disease, and although he has a doctorate in physical therapy, he is best known for his role in teaching lipid physiology. He serves as an adjunct professor at several medical programs, and his goal is to help you, whoever you are, to not have heart attacks, strokes, and dementia by explaining complicated biochemical concepts in a relatable way. Employing a smorgasbord of metaphors, pictures, and catchphrases, his latest book, The Home Security System and the Lipid Neighborhood, serves as a valuable reference for clinicians and non-clinicians alike, bringing refreshing relatability to complex biochemical topics. Through the lipid lens, you'll learn, laugh, and love your way through its pages. And in the end, you'll undoubtedly add life to your years. Josh is active in youth ministries at Heritage Bible Church in Boise, Idaho, and resides there with his family. He also enjoys CrossFit, basketball, ultimate frisbee, and all sports that don't involve skates. Josh Wageman, what an absolute honor it is to welcome you to Boundless Body Radio.
Hey, thanks for having me. It's a privilege.
No skates, man. What's up with that? Those are my favorite sports.
Dude, I feel like I'm pretty good on my feet. And then as soon as you put any wheels underneath me, all semblance of coordination is lost. And then I call it paranoidage, where you know too much and then it ruins your day. And so when I put skates or wheels on, I'm thinking, okay, I'm going to tear my medial meniscus. And then I start talking about the mechanisms at play that result in meniscal tears. And then no one wants to be my friend anymore. So anyway, yeah, it's pretty rough. So I stay on my feet and I feel like I'm pretty decent there.
Well, at least you found out what you are good at and what you're not good at. I love ice hockey. I just told you, I reside here in the Salt Lake Valley, so we just got an NHL hockey team, so that's been really fun to follow. And also with the Olympics here, we get to participate in all kinds of different winter sports, including a brief stint I did in short track speed skating. And let me tell you, as far as like ACL, worrying about injury, like that was one of the most brutal sports I've ever done in your life. Like a minute and a half just doing laps around, like even like 14, 15 laps around a hockey track is absolutely brutal, terrible. So you're not really missing anything there, let me tell you.
Yeah, it's impressive though. I mean, I love all athletics, and anybody who can do any of these things at a real high level is impressive. I'm just gonna watch rather than actually try myself because live to fight another day becomes one of my mantras, particularly as nearing 40 years old now.
Yeah, exactly. We got to go to work on Monday morning, right?
For sure.
Okay. Well, it's amazing the work that you've done in so many different multiple fields, and I want to talk about your own personal journey. But we mentioned a few times in the introduction that you have a gift for breaking down very complex biochemical systems inside the body and explaining them in the way that people can understand it. That really shone forth in the recent interview that you gave on our mutual friend Brian Lenskis's podcast, the Low Carb MD. You did such a wonderful job in explaining such a complicated topic. What do you think it is about you and your makeup that is able to explain some of those things in a way that bums like me can understand?
Well, thank you for the kind words, and that was such a blast going on with Dr. Lenskis, a phenomenal guy, and so great doctor, and even better person, and so that was great. So one of my mantras is to walk with kings, but not lose the common touch. Because I try to have this truly regal understanding of physiology, but if I can't disseminate that in a way that people can understand, then no one's going to be my friend, and then we really haven't accomplished anything. And I've seen a lot of patients over the years too. And I really want people to optimize their quality of life and their metabolic health. And we can look at all these things. We can go over your labs. And if you don't have ownership of the process yourself, and somebody is just telling you, do this because I'm a doctor or I have whatever credential it is, it's not going to stick. But if you can have an understanding of the process, then our rationales are going to make sense. And then we can get there together. And so that's why I've found that if I can use a lot of metaphors and I can use catchphrases, then people are going to be like, oh, okay, this makes sense. And then we can arrive at that conclusion together. And so that's where stories are critical, and that's where people live, I think, I mean, not many people enjoy biochemical signaling pathways and drawing all these things out. And that's kind of weird. I enjoy that, but I enjoy reading textbooks as well. And so, I've filtered through those things, and hopefully I can come away with the salient information that will resonate with you. And then we can go on and have a good time together and and add some life to your years in the process. And so, that's one of my goals with the framework that I've created and all these different metaphors I use, particularly when it comes to cardiovascular health, because heart disease is the number one killer of people across the globe, and nobody wants to have heart attacks, strokes, and down the line dementia. And so that's where my framework, the home security system in the lipid neighborhood, kind of comes into play, and that's one of the reasons why I wrote the book.
Yeah, amazing. And yeah, it's so mind-boggling to me that we changed all of our guidelines, 50, 60, 70 years ago to solve really one problem, which was heart attacks. And not only is it still unsolved, like the number one killer, like you said, is still heart attacks, but we have all these other things that we weren't dealing with back then. The diabetes, the obesity, the dementia, all these other things that came along with it. It just always boggles my mind to think that we changed our guidelines to fix that one thing. And not only did we not fix that one thing, it's still the number one killer, but we have all these other things we're dealing with. It's terrible.
Yeah. Yeah. And there's a lot of confusion going around, like what cholesterol in particular. I'm a lipid specialist. And so, people don't know what to believe. And one day there's a shirtless influencer telling you that, yeah, eggs are everybody should, all you eat is eggs. And then the next day there's somebody else saying that this is the worst food you can ever eat. And, and what to believe, for the consumer, for the layperson. And so that's one of the reasons why I wrote my book as well, just because, hey, let's have a fundamental understanding of the biochemistry that the good Lord hath ordained. And then we can look at our clinical data. We can look at the genetic data. We can look at all the things that we can ascertain from science and make better sense of what we're seeing there so that we can hopefully, just optimize our cardiometabolic health.
Yeah, of that. Before we deep dive into the contents of your latest book, let's talk about your own journey into health. Was it pretty early on in your life that you knew you wanted to get into the medical field and wanted to help people out there?
Actually, no. I grew up and I've always been a huge nerd. I mean, I memorized all the capitals of every African nation when I was in second grade, just for kicks and giggles. And I would just memorize stuff just because. And I mean, I couldn't see. This is actually interesting. So when I was a little kid, I have always had terrible vision, but I just figured that's, nobody could really see anything. And I was living in this nebulous fog. But anyway, what I would do is I would walk up to the chalkboard, which, there were chalkboards back then. And I would just memorize everything that was on the chalkboard. And then I would go and sit at my desk. And, that was how I thought people went about. And so I couldn't see anything and no one really knew. And so that's how I went around. And then one day after school, I start yelling at who I thought was my friend Chris across the playground, and my mom was there, and I went up and I got about 5 feet from him, and that was not Chris. And she's like, "Are you serious with that?" And so anyway, but basically I went around and I really couldn't see anything, and I played sports too. And I think that helped me just be in touch with my body. And I was just basically using the force, I guess. But I'm, playing baseball, basketball, soccer, and I was a pretty good athlete. So yeah, but really couldn't see a darn thing. And then when I got contacts, I was like, wow, this is amazing. The gift of sight. So anyway, so I was really, my idolatry was athletics, and I took for granted how easy school was for me. I liked it. I enjoyed it, but I didn't really have to do much. And, I really emphasized athletics. I think during my high school experience, I was planning on majoring in broadcast journalism, actually, believe it or not. And just because I was like, hey, after I'm done, playing sports, then I'll just go talk about them, and that fantasize about those things, being in the booth, pontificating with Stephen A. Smith or something like that. So anyway, so I had very, very shallow motivations for doing pretty much everything I was doing. And really it was when I got really sick in grad school the first time. I was running cross country and track for Idaho State during physical therapy school, during my first doctoral program, and I got incredibly sick. And that was when God shattered me and humbled me. And a lot of times those difficult situations are catalysts for paving the way for what you're really supposed to do when you grow up. And so that was when I really started to reevaluate my perspective and say, what am I doing? Because I put all my eggs kind of in the athletic basket for way too long. And that was, my priorities were way out of whack. And so anyway, so I finished up PT school. There was never a sense of finality there. And I fell in love with biochemistry and endocrinology when I got really sick and nobody could really figure it out. Because I was like, this stuff's pretty cool. It's not cool when you're living it, but it's really interesting stuff. And so I invested myself in that, and I figured the quickest means to my end to eradicate metabolic dysfunction from the world, or at least help assist in the process of improving people's metabolic health, would be to go to PA school rather than med school at the time. So I went to the Yale School of Medicine for that. And then I couldn't help myself. And I have very few useful skills except going to school and taking tests, as you can see from the comically viscous soup of letters behind my name. But I worked on a PhD focusing on cholesterol disturbances and Alzheimer's after that. But during that time, I was actually practicing clinically as a physician assistant and became a lipid specialist during that time. I wish I had a good humanitarian reason for becoming a lipid specialist, but basically it was because I read an article that was supposed to be a rudimentary review of cholesterol homeostasis, and I didn't understand much of it, and it made me mad. So I was like, all right, well, that's unacceptable. And, you know, in the process, right, if you can learn something that could potentially help someone, why wouldn't you want to do that? And I figured, hey, you know, since this is ubiquitous, and since at that time, all I had been taught in school was LDL bad, HDL good, everybody take a statin. And I figured there was probably a little more to that story. I was like, well, let's learn this stuff. And that kicked off this cascade of wonderful events. And now I write books about all this stuff. So anyway, if anybody has a remotely similar background to me as far as their academic and career journey, I'd like to meet that person because it has been wonderfully convoluted and circuitous, and but I wouldn't trade it for anything.
Yeah, I am not familiar with that person. I know you and you only that has gone through all of that. That's quite a bit. Did you ever practice as a physical therapist?
Oh yeah, for many years. Yeah,
Okay.
and that was a huge blessing. I mean, anytime you're able to invest in someone's life, that's a great deal. And you know, with PT, I was mainly outpatient orthopedic PT, but what was really cool, one of my favorite things was actually when I was practicing in neurological physical therapy. And there were many people with Parkinson's disease. And the benefit of exercise in Parkinson's is amazing because with
Huge.
Parkinson's disease, you know, they have this damaged basal ganglia, and they're not no longer producing dopamine from the substantia nigra in their basal ganglia, and so that's why we have those characteristic tremors and the freezing episodes and some of the problems with gait and ambulation and all the other things. But what's amazing is the brain, the neuroplasticity in the brain's crazy. And so you can, with exercise interventions, actually kind of bypass some of that damaged circuitry. And these people get their lives back. I mean, and it was cool. And music, you know, bring in your favorite CD. Yes, CDs. We were using CDs then. And, you know, they're able to actually start moving, you know, these people who haven't moved well forever, now they're back to playing basketball. We're doing little, you know, we would start like in the parallel bars just so we don't fall, but we would be doing kind of like modified agility stuff. And it was awesome. So I really that was one of the most fun things I did was neuro PT, and just people who, you know, have things like Parkinson's disease, and they're doing so well. And they even have boxing classes actually for people with Parkinson's disease, community classes, because, you know, you're crossing midline, you're doing dynamic things, you're doing protective stepping, working on your balance. And so anyway, so that was kind of my first little taste of neurodegenerative disease, which is a focus of mine now, mainly in the lipid realm. And what's really interesting is, yeah, when you're a hammer, everything looks like a nail. I'm a lipid specialist, so everything looks like a lipid disorder to me. But there is a lot of overlap between things like Parkinson's disease and Lewy body dementia and Alzheimer's disease and some of the toxic lipid droplets that accumulate in the wrong places in the brain in all of these conditions. And so there's significant overlap in the neurodegenerative disease continuum. So anyway, so I was a long tangential answer to, I did practice in physical therapy, and I'm also a strength and conditioning specialist, which is another one of those things. And that I have that required, you know, going and taking a board exam. So anyway,
Just one more
yeah,
thing. No
yeah,
big deal.
just might as well, right? If there's a test out there, you know, I'll probably go take it just for fun. So.
Mm. Well, I have an example of a really good friend of mine who's also a personal trainer, was hired by one of my former clients to work with his mother who is aging and also had Parkinson's. And he would just go over to her house and simply put on a record. I'll take your CDs and go one generation further back. He would take whatever her favorite record was and would just dance with her for an hour. And I don't know that it added many years to her life, but it certainly added a lot of quality to her life in the very end. And so that was a really standout kind of example of something I recall before I understood the science of any of that, that how good movement is for mental conditions, especially with Parkinson's. Pretty interesting.
Movement is medicine, motion is lotion, you know, whatever catchphrase you want to use. It's
Yeah.
amazing.
Yeah. So I did want to ask you before we get to your book, something you were taught in physical therapy school that you found to be either not true or less true than you thought.
Physical therapy school. And so I was a knucklehead in PT school. I'm not really sure what I was doing. I was running around and going rock climbing when I should have been in class. So I'm taking it back to what I was supposed to have learned. Some of the modalities, as far as the like ultrasound, that you're taught to do in PT, there isn't real strong evidence behind it, and so that's one of those things where you learn, you're like, why am I doing this? You do it if the person thinks it'll work, and so that's really that. You know, PT, good movement fixes most things. And so I've had the blessing of playing lots of sports throughout my life, and I can identify aberrant movement patterns pretty quickly. And aberrant movement patterns, they hurt. They not only hurt those who are watching. You go to the gym, you see somebody deadlifting with a rounded back, and all the baby seals are dying. And you're like, oof, you're cringing. Well, if you can teach that person to lift better, I bet their back won't hurt as much. And so just grooving good movement patterns fixes a lot of stuff. And so just understanding movement is really key for PT. All the other bells and whistles, some of the manual modality stuff, it's a little bit. Is there strong evidence behind it? No, but I do think there's an unquantifiable benefit to just investing in a person's life, building a relationship, and then when you're just moving through them, even if it's passive range of motion, just having that human connection via personal touch, not the creepy kind, is actually super important. So you can do the same thing as a physical therapist. And a lot of times people will benefit just from doing something rather than nothing, right? Because people are sedentary. So if you do something, even if you don't know what the heck you're doing as a PT, which I encourage everybody who's doing whatever they're doing to, know what they're doing. But even if you don't know what you're doing, if you just have somebody do something, they're probably going to do better than nothing. And a lot of times too, it's just about the relationship you build, rather than the actual intervention. And, oh, I had them do this exercise. Well, if they're having fun and they like you as a person, they know that you want them to get better. that's probably where most of the magic lies, unless you're doing something completely irresponsible, like having people jump off of buildings or something just to try to, groove some sort of plyometric. So anyway, PT is great. PT is a wonderful profession. And it's PT school was just a long time ago, and I wish I actually would have had a better perspective during PT school, because I was in a weird place mentally and emotionally at that time. And what's funny is sometimes I'll go back and I'll talk to my physical therapy professors, and they're like, "Oh, we're glad you're doing okay. We were worried about you." I'm like, "Yeah, well, thanks." Because it was just an interesting time and a real shift for me, just because I had to be broken from my athletic idolatry to really reevaluate my perspective on what was important in life.
Yeah. Well, thank you for that. I really appreciate that. I've gotten to meet many wonderful PTs out there. Got to talk to a lot of them on this podcast, which has been great. But I also see like the programs that people have, and it seems like every shoulder injury, you just have this generic printout that you're supposed to do, 24 times or 36 times or whatever the insurance covers, and it's just like this kind of generic kind of program. So anyway, I really like that explanation. And let's dive into the contents of your book. However, you want to introduce us to some of the concepts to help us understand how lipids work inside the body. The title of your book, obviously, The Home Security System and the Lipid Neighborhood, is an interesting way to think of things. So can you tell us how the nexus of your book kind of found its way to you, and how you explain some of these concepts?
Sure. And so, what I always start off with is, for everyone who does not want to have heart attacks, strokes, and down the line dementia, I want you to have a great home security system, and I want you to live in a safe lipid neighborhood. Your home security system has 4 basic pillars: normal blood pressure, normal blood sugar, keep inflammation low, and don't smoke or do drugs, because those are bad. But then your lipid neighborhood is your cholesterol panel, because every ApoB containing lipoprotein, the vast majority of those being LDL particles, are potentially criminals that can infiltrate your arterial abode. And the LP little a particles, if you pick the wrong parents with that genetic risk factor, those are the felons. Because per particle, they're about 6.5 times as likely to cause mischief than your run-of-the-mill LDL particle. And so can always look at the 4 pillars of your home security system. We can check your parameters of glucose metabolism. And it's not just blood sugar, it's it's really insulin and blood sugar. Control your insulin, control your life is one of my mantras. But really, we can look at your parameters of glucose metabolism. We can look at your blood pressure. We can look at measures of systemic inflammation. If you're doing drugs, you should probably stop. And so those are axioms. No matter what your lipid neighborhood's looking like, these are constants. Nobody ever wakes up and says, I wish I had uncontrolled blood pressure today, or my 2025 New Year's resolution is I want to be more insulin resistant. Life is not better inflamed than non-inflamed. And then guess what? Doing meth is still bad. So anyway, so all these things are axioms, so we can agree on these 4 pillars no matter what. But then the lipid neighborhood, well, it might look on paper like you're living in a rough inner city neighborhood just on your cholesterol panel, right? But people don't live on paper, do they? And so do we have better ways that can inform our decision-making process with your lipid neighborhood? Well, one of my catchphrases is got plaque, get a CAC. What's a CAC? It's a coronary artery calcium score. And I call it the colonoscopy of the heart without the nasty pregame show. Because anybody who's done the bowel prep for a colonoscopy knows that will temporarily ruin your social life and probably destroy your bathroom also. So, but this CAC, you lay down, it's a low dose CT scan, about the same amount of radiation as a mammogram, so virtually nothing. And it tells you if you have calcified plaque in your coronary arteries or if you don't. And if you do, you've been broken into. And you cannot have atherosclerosis without one of these ApoB containing lipoproteins going rogue. It's like a mailman going rogue, one of these LDL particles. And so you can't have atherosclerosis without one of those guys in the wrong place at the wrong time. And then it's the maladaptive immune response that results that gives you coronary plaque. So if you have a positive calcium score, if you have any evidence of break-in to your lipid neighborhood, well, you're living in a lipid neighborhood that's a little bit too rough. And so do you want to keep living in that same lipid neighborhood where you got broken into? Or do you want to maybe consider moving to a nice, safe, gated community with fewer lipid criminals if there's been evidence of a break-in? I think that's reasonable. And then we unpack how we can do that and some of the tools in our toolbox that can help you getting to live in a safer lipid neighborhood, to help shift the paradigm from reactionary to preventive, because all too often we just wait around for people to get worse when it comes to not only heart disease, but insulin resistance too. And that's one of my big deals. Chapter 1 of my book is all about control your insulin, control your life. That's one of my mantras. And because really, it's not just about keeping blood sugar normal, it's about keeping insulin levels normal as well, because hyperinsulinemia with or without hyperglycemia drives a lot of chronic diseases. And one of the problems too is, when you're insulin resistant, well, that means that your cellular mailboxes are getting full. And if the mailman, which are these ApoB containing lipoproteins, which their job is to just deliver triglycerides, a few phospholipids, some fat soluble vitamins to target tissues, and then go home at the end of the day. If your mailboxes are full though, and the mailman are going to try to deliver mail in your mailboxes, well, what's going to happen? They're going to keep driving around. And if they're not delivering the mail and they're not going home at the end of the day, they're more likely to run their trucks in your arterial wall. And so insulin resistance is no good. And keeping, blood sugars and parameters of glucose metabolism optimal is essential for so many different reasons. And really what we do is we wait around. It's like, oh, you're pre-diabetic. Well, let's wait around for you to have type 2 diabetes. Then we'll do something about it. And quite frankly, insulin resistance and impaired fasting glucose and prediabetes and diabetes, it's all in the same continuum. It's like being almost pregnant. You are, you aren't, just how far you are along that process. And with coronary disease, if you have any plaque, you've been broken into. So do we want to wait around for that plaque to rupture and you be 100% occluded, which that's how majority of cardiovascular events happen. It's not this, progressive stenosis, where you have a little plaque and then you get a little more, and then it's progressively narrowing. No, 2/3 of heart attacks occur in when there's a little bit of plaque there and it's vulnerable, and then it ruptures, and then bam, you're 100% occluded and having the big one. And so if we can do things to mitigate insulin resistance, if we can do things to get ahead of the game when it comes to coronary disease, and if you have any plaque, I'd prefer that plaque stable, and we do have ways to stabilize that plaque and even regress that plaque potentially, then we should do that. And so really that's a lot of the book is really starting out with that home security system and that lipid neighborhood framework. And you can always, that's ground zero, because some of the stuff gets really complicated, and when we start talking about, some of the nuances of cholesterol homeostasis, your head can start spinning a little bit, but it's like, hey, that's okay. just get back that home security system in Lipid Neighborhood, got plaque, get a CAC. Oh, okay, we're good. Because most people, that doesn't get quite overwhelming. And that's where we go from there.
Got it. Well, I love that. And I love asking the question of experts like you, what is insulin resistance? And I love asking that question repeatedly because everybody has kind of a different flavor, a different way of explaining it. I love the visual of the mailbox that's getting too full. Can we go into a little bit more detail about why somebody would become insulin resistant? What would be the cause of that? Why that is the very first chapter of your book? What to do to get out of it? Like you said, maybe regress that. And then why it's so important to not only be checking your blood glucose, but also your insulin, like you mentioned.
Yeah. And so really insulin resistance just means that you're in a state of overnutrition. And so really all our cells, and so we've got our fat cells and we've got our muscle cells. And when you eat anything and you have any fuel on board, you can readily use it in the muscle cells, or you can store it in your fat cells. And fat cells are like little suitcases. And basically, you can put some clothes in the suitcase and go on your merry way in the subcutaneous fat cells. But at some point, and there's a lot of genetic variation. It's called liposusceptibility. And some people are able to create more suitcases, and some people's suitcases seem to be able to expand indefinitely. And then other people, you just don't have a whole lot of room in your suitcases. For instance, people from like Laos and Vietnam, I had these patients from Southeast Asia, and they're little dudes. They weigh what I weigh, which I won't tell you what that is. It's not very much. And so anyway, the same weight as I am, but they got just a little gut on them, and they've got, type 2 diabetes, A1C of 12, and that's just because they're just not very good at getting fat. They have very few suitcases, and those suitcases don't expand very well. And so the moment that you run out of room in your suitcases, you eat, and insulin's a storage hormone. Insulin is like, all right, well, we've got clothes here to put in the suitcases, but there's no room. So what's it going to do? It's going to drape those clothes around your liver. It's going to drape those clothes around your pancreas. It's going to drape them around your heart. You get fatty heart when you're insulin resistant too. That probably should strike you as a bad thing, and it is. And so really, that's really a huge problem, because that visceral fat, once you're out of room in your suitcases and it spills over into those ectopic depots, it's so pro-inflammatory, and it sets off a whole terrible immune response, and your body resents your chronic state of overnutrition and attacks you basically from the inside out, rather than actually focusing on any sort of bacterial invaders like it should. And so that's really insulin resistance, and then I paint it another way when I talk about lipoproteins, just because, people a lot of times they don't understand the purpose of these particles, like the VLDL, IDL, LDL particles, the ApoB particles that could get in your artery wall. They think, oh, LDL bad, Well, no, it's not inherently bad. Mailmen are not necessarily bad dudes. It's just if, the mailman is a bad driver, if he's a bad dude. And so really the whole purpose of VLDL, IDL, LDL particles is to be mailman, to deliver the triglycerides to the fat cell or the muscle cell, and then eventually go home to the liver at the end of the day. And the reason why the LDL particles tend to be the one that is focused on the most is because they just linger a little longer than the VLDL and IDL particles. VLDL particles come out with a bunch of triglycerides, so a bunch of mail on board, and then they deliver the mail, and then they become an IDL, intermediate density lipoprotein. And then the IDL delivers a few more pieces of mail and then becomes an LDL. And the LDL particle, mainly because it lacks something called ApoE, it just has a longer plasma residence time. So instead of being around for a couple hours like a VLDL, IDL, it lingers a few days. Okay, well, if you're loitering, then you're more likely to get into trouble, right? We see those kids on the street corner, and after school, if they're not going home, are they doing charitable community activities? Probably. Well, probably not. They're probably going to get into trouble. And so, the longer one of these particles is out there, not doing what it ought to do, the more potential it may have to, especially in the context of a compromised metabolic milieu, run the truck into your artery wall where it doesn't belong. And so really, establishing the teleology of these things, establishing that, a lack of cholesterol is incompatible with life, but you can't have this atherosclerotic process begin without a cholesterol-laden perpetrator in your arterial intima, and helping people contextualize that, because people a lot of times want things to be binary. It's like, oh, this is good or this is bad. It's like, oh, no, it depends. And most of these things depend on the context in which you live. And that's why diabetes is so terrible, because you get caught in a sugar storm. Is it really easy to drive when you're caught in a storm? I mean, you live in Utah, I live in Idaho. I got caught in a blizzard one time, and I lived the song "Jesus Take the Wheel." And I spun out and flipped my car a couple times, and God decided it was not my time to go. It was terrifying though, and that cliche where everything slows down. Oh yeah, it does. It was wild. And I still have recurring nightmares at it. The subconscious is another fascinating topic. I'm
Wow.
like, it's not like I'm, go around paranoid or something. I just wake up, I'm like, oh, good. I'm glad that was a dream. Go to the bathroom and go back to bed. But anyway, so, but it's hard to drive in a storm, Well, guess what? When you have diabetes, you're caught in a sugar storm at all time. Well, the mailmen are out there trying to deliver the mail in the sugar storm. You think they're going to do a good job? No, and that's why there's a 2 to 4-fold increased risk of coronary events in people with diabetes, because you're caught in a sugar storm as well, and that's independent of some of the effects of hyperinsulinemia on endothelial function and some of those real deep dive things with the effect of high insulin levels. And so anyway, so there's all sorts of things that go wrong there. And if I could pick one thing not to be, it would be not be insulin resistant. And so that's great. And so I've chosen to not be that. But really, insulin resistance is, in that chronic state of overnutrition, but we have many levers to pull to restore insulin sensitivity, both non-pharmacologically, and we have some pharmacologic catalysts as well for people who I need to undo the last 30 years of their life. And so anyway, we got tools in our toolbox now.
The sugar storm is a really good analogy. I like that a lot. Does it make any sense to you that the American Diabetes Association is recommending that diabetics take anywhere from like 40 to 60 grams of carbohydrates in every meal?
It makes absolutely zero sense at all, and diabetes is basically a disorder of carbohydrate metabolism. And so, telling somebody with diabetes, oh yeah, just eat the good carbs or whatever, is like me telling a kid with a, peanut allergy, hey buddy, it's all right. So let's just, eat the organic peanuts and keep your EpiPen handy, and we'll be good to go. And this would be particularly with somebody with diabetes who's on insulin, who still makes your own insulin. You just don't use it very well. And so no, it makes absolutely zero sense. And really, are there different ways, can people who have diabetes, reverse their diabetes with, a caloric restriction approach? Yes, that's possible. I'm a big fan of carbohydrate restriction for people with type 2 diabetes. I've seen lots of patients with type 2 diabetes. And the problem is the most profound biochemical response as far as insulin secretion is to dietary carbohydrates. And you don't do a good job. You are not controlling your insulin or your life. And you're still making insulin. If you have type 2 diabetes, you still make insulin, you just don't use it well. And what's unfortunate is the more insulin you secrete, the more you desensitize the insulin receptor. And so if you're continuing to flood the system with carbohydrates, are you getting anywhere? You aren't. So let's take away your carb privileges and reverse your diabetes. And it works. It works, And so, and then, as if you've reversed your diabetes, can you, potentially not be quite as, monastic about your carb restriction once you've done that? Well, yes. But at the same time, giving people structure, and you're not saying, well, everything in moderation. No, everything in moderation is what's got us to the standard American disaster we have today. And so I think the context dictates those things. And, I think that also, it's not like carbs are evil, and especially if you are an athlete who is running and sprinting and all these things. I mean, if the furnace is hot enough, it will most likely burn to a point. And so context matters, and my big thing for diet is I do think there's outsized benefit with carbohydrate restriction for people with diabetes. However, in general, what do I say? I say prioritize protein, eat real food. And that's what I do, and so I mean, and a lot of times, if people are in ketosis and then they cycle in and out of ketosis, okay, that's normal. That's called normal. Just because our bodies are meant to naturally cycle between fasting and fed states. And, I think that's things work pretty well in that regard. And so, however, when people are extremely sick, i.e. type 2 diabetes, I think more extreme measures are warranted. And the low carbohydrate approach, and there's so much data on low carbohydrate approach for type 2 diabetes, and it's no coincidence. You make a bunch of insulin, your insulin receptors plug in their ears, they don't get the message. well, let's restore insulin sensitivity and then go on our merry way.
It's pretty obvious, like where both of us live, there's a time of the year where carbohydrates are going to be exceedingly rare. They're going to be really hard to find, but you're going to find some. You're not going to find a lot, but you're going to find some, unless you're cultivating them or doing some type of agriculture practice or having a garden or something. And then there's this other vast majority of the year where you're not going to find any. Like they're going to be gone. They're not going to be available to you if you didn't save any or store any or preserve any in some different way. And even in, the more tropical climates of the globe, you just don't see the tons and tons and tons of edible carbohydrates growing for you all the time. We take vacations to somewhere nice and warm on the beach. You just don't see tons of fruit everywhere. You don't see wheat everywhere. Like you just don't see it that much. And so it's kind of understanding it from that lens. It's like we just have it in such a vast quantity, and it's available all day, all week, all month, all year for decades, that causes insulin to be a problem, when, like you said, like bouncing in and out of ketosis should be a very normal kind of a thing that anybody should be able to do at any time.
Yeah, and we don't see Doritos and Dorito packages growing anywhere across the
Never
globe
seen
at
that.
any
I've
time of the
never
year.
seen that.
And so we live in a very unique time where things are almost too easy, and food is readily available and accessible and hyper palatable and all these things. And that's why, I mean, I spend a lot of my time, I do, youth ministries. I coach cross country. I mean, that's the good stuff. You go and run around, you play all day, and then it's like, oh, okay. Oh, yeah. Okay. Well, let me grab something to eat, and fuel the machine a little bit and go keep on playing. I think that food is such an event for us in America. When I go fill up my car at the gas station, I don't say, oh, this is awesome. Hey, I'm going to call up all my friends and family. I'm at Chevron pump number 2. I mean, I know I put car in the gas in my car and then I go on with life. Right. That is how I view food. And I mean, people be like, "Oh, come on, man!" And I know I'm weird, but I derive my hedonism from movement, and the people that I get to experience these amazing blessings with. And so the food itself, it's like, okay, well, I'm going to try to put some quality fuel in the machine so I can go run around and go crush it at life. And I think that, yes, there are special events, right? Somebody's birthday or whatever, and where you go to a nice place. And, when I give a dinner talk on, lipoprotein little a, I wine and dine people and, and pay for their food and whatnot so that they're obligated to listen to me talk about lipids. But, there are special events. But I think that the main event multiple times a day is, oh, where are we going to eat? Where are we going to eat? No, let's get away from that and just treat food as fuel. Food is fuel. And then let's go use the fuel to go absolutely enjoy the wonderful gift of movement that we have in this life. And so that's my mentality. It's just fueling the machine and not putting so much outsized emphasis on, what you're eating and where you're eating. And I think that's really a better philosophy in general.
Yeah, well said. I like that. Okay, let's get back to cholesterol. You said that we like binary explanations. We like good and bad. And so everybody knows, if I ask anybody on the street, everybody knows there's good cholesterol and there's bad cholesterol. You wrote an entire chapter about what even cholesterol is. You wrote an entire chapter about lipoproteins. Again, most people know good cholesterol, bad cholesterol. Good cholesterol, we want high. Bad cholesterol, we want low. We think we get most of our cholesterol from the food that we eat, even though since 2015, the U.S. dietary guidelines have buried in there, say, somewhere that cholesterol is no longer a nutrient of concern. You can have as much as you like, according to those guidelines. How do you explain that to people who really want that binary approach of good versus bad?
Yeah. So I'll unpack this a little bit. And so LDL cholesterol is called the bad cholesterol. And I already said, well, these things are not inherently bad. They're mailmen, right? That mailman could be a bad mailman if he's a bad driver or runs his truck into your arterial wall, but they're not inherently bad as long as you're, going home at the end of the day, which home is the liver. And so now HDL cholesterol, this is the good cholesterol. It's an erroneous statement to say that there's good and bad cholesterol. It's the same 27 carbon molecule, regardless of, it's just a matter of what lipoprotein it is incorporated into and where it's going and what it's doing. So the cholesterol itself is not the problem, and a lack of cholesterol is incompatible with life because cholesterol is an essential part of our cell membranes. It's an essential part of bile acids. It's an essential part of steroidogenic hormones 20 to 25% of our total body cholesterol is in the brain, and it's incredibly important for synaptic transmission in the neuron. And so it has this whole host of amazing physiologic properties. However, so calling it good or bad, well, no, but the lipoprotein that it is incorporated into, we need to further unpack that. So HDL cholesterol. And so they'll say, oh, HDL cholesterol is good. And a lot of times people will say, oh, my ratio is good, right? My triglyceride to HDL ratio is good. Well, that's a good thing. That is a proxy for insulin resistance. And there are many ways to identify insulin resistance. We started to allude to fasting insulin is a great thing to add on to your fasting glucose. If you're comfortable with C-peptide, that's another marker that will clue you in onto how much insulin you're secreting. Triglyceride to HDL ratio in general is a proxy for insulin resistance. But just because you have a good ratio doesn't tell you the whole story. And the big key takeaway with HDL cholesterol, HDL is so complicated, is that a static measure of HDL cholesterol gives you no idea of its functionality. And so HDL cholesterol, these HDL particles do good things. They're like the police force. They are capable of going into your arterial wall where there's been a little bit of a break-in, and they are able to suck that sterile-laden perpetrator out of the arterial wall and take it back to the liver. And that's called cholesterol efflux capacity. HDL particles can actually do that, which is really cool. And it's actually the smaller ones, the little cops, and the motorcycle cops that tend to be better at that, which is interesting. And then, the HDL particles are capable of binding up lipopolysaccharides. And so if you're having a bad day, you have sepsis and it's gram negative, lipopolysaccharide accumulates and that can kill you. That's not good. But HDL particles can actually bind up lipopolysaccharide. They can take it back to the liver, and then those toxins can be excreted in the bile. So you live to fight another day. That's good. HDL is actually important in endothelial function as well as glucose uptake into skeletal muscle. Well, heck, that's a charitable community activity, utilizing glucose a little bit more efficiently. So HDL particles can even do that. But just looking at, my HDL cholesterol is 60 on my blood panel, you don't know if it's doing that or not. You have no idea. And so there are people with really high HDL cholesterol that have dysfunctional HDL cholesterol, and they have accelerated coronary disease. And then there are people with low HDL cholesterol who actually have a superpowered functional HDL cholesterol. It's called ApoA1 Milano, and they get no disease, and their HDL cholesterol is just amazing. They have very efficient ApoA1, which is the primary structural lipoprotein on HDL particles. However, low HDL cholesterol. Is low HDL cholesterol probably a bad thing? Probably. And if you're going to use HDL cholesterol for anything, in general, it's like the hemoglobin A1C of how high your triglycerides get after you eat. So hemoglobin A1C, average blood sugar for 3 months. Well, HDL cholesterol, if your triglycerides chronically go way, way, way up after you eat because you're insulin resistant, your HDL cholesterol over time will go down. And here's why. And so when you have a ton of triglycerides that aren't, so basically mail that's not getting put in your mailboxes, well, the HDL particles get fat and fluffy with the excess triglycerides. It's like a police officer that's getting overweight and is not going to pass his fitness test. So what happens is your body is always trying to do damage control. Our body's amazing at not dying, but there's a big difference between not dying and truly living. So anyway, so your body's like, all right, well, these HDL cops are getting too fat. So what happens is endothelial and hepatic lipase come in and they try to do a weight loss procedure on these fat bloated HDL particles. Problem is they overshoot it. They're not real good. And so what happens is you're left with this gaunt, emaciated HDL particle that is now too weak to pass this fitness test. And so your body's like, all right, well, let's remove you from the police force. You did not pass your fitness test. And so it's actually your kidney via something called megalin and cubalin that catabolizes the remaining ApoA1 on that gaunt, emaciated HDL particle. So over time, when you're continually eating and you're in that chronic state of overnutrition and triglycerides are spiking up, what happens is you see low HDL cholesterol, and that's why it's part of the metabolic syndrome. And so really it's cool when these things make sense though. It's like, oh, that's why we're seeing that. And so, but really it's just telling you about the metabolic milieu when you see low HDL cholesterol in general, rather than, oh, that HDL particle is not doing his job. Well, you just don't know, and really there are so many proteins on HDL. There are hundreds of proteins on each HDL particle that can kind of dictate whether or not it's functional or not. And we don't know yet, and so anyway, so HDL is complicated. And so, relying on a static measure to tell you what to do or not do, is a little bit irresponsible there.
Yeah, got it. Okay. I like the A1C comparison. I almost think of the A1C number as also like a BMI number. Like in an individual, it might not be able to tell you that much. In a population, it can sure tell you a lot. And yeah, if your HDL is chronically low, that's probably not a good thing. Which brings me to ask you about diagnostics. So we mentioned a few. You've already mentioned a lipid panel. We've got basic lipid panels. You've got NMRs, which are a little bit more complicated, more expensive, but they give you more information. We also have the diagnostic tools like a CAC that you mentioned, or CT angiogram. Some people do carotid artery checks. Like, what, in your opinion, what are the best diagnostics where you get the most value and you can see what is going on the most to be able to guide decisions?
Great question, and real practical. And so really that, adding a fasting insulin. So you got your complete metabolic panel, right? You got all your electrolytes and you've got your fasting glucose or your glucose level. Tacking on a fasting insulin is real low hanging fruit because you can calculate what's called a HOMA-IR based on that. And that's when you multiply your fasting insulin times your fasting glucose, divide by 405. And that will tell you, hey, am I making adequate amounts of insulin to keep my blood sugar, whatever it is, hopefully normal, or am I making too much? And so adding on a fasting insulin is wonderful to your, basic metabolic panel. Additionally, that when from a lipid perspective, ApoB is a marker that's in vogue. And that's because, like I said, every particle is potentially a criminal, not necessarily a criminal, okay? A mailman, but potentially a criminal. And so if you get an ApoB, ApoB is a measure of the particles rather than just the mass of cholesterol. The mass of cholesterol really doesn't matter. It's just how many particles you have delivering that same amount of mass. And so ApoB, you can get an ApoB. And when ApoB is high, even though your LDL cholesterol is, quote, normal, those are the people that tend to have cardiovascular events, okay? But do you need an ApoB? Well, if you understand it, and anytime that you're getting a biomarker, if it's actionable and if you understand the utility of it, then by all means get it. However, just for your run-of-the-mill person out there, add their fasting insulin to your basic metabolic panel. And then with your basic lipid panel, get a lipoprotein little a, the LP little a, the felon of the lipid neighborhood, because it's good to know. And it can be an independent risk factor for cardiovascular disease. It can be your only problem, I should say, and you can get broken into. I have a friend. He is an absolutely amazing athlete, and his 10-year risk calculator, which those are garbage, it was 2%. And his family history was no good. I said, dude, get your LP(a) checked and get a CAC. His LP(a) was quite elevated, and then his coronary artery calcium score was 2,814. And so basically, any score above 0 on your CAC means you've been broken into. Any score of 300 or greater, you have the equivalent risk of having a coronary event as people who have had prior MIs, even over short term. 2,814 is kind of like, wow, how are you still here? And so he had to have a 5-vessel bypass a year ago. And then a few weeks ago, he actually did the half Ironman up here in Boise and even qualified for Worlds in France because he's awesome. So anyway, but basically, yeah, not knowing doesn't make it go away. And he picked the wrong parents with LP(a). And so I would say LP(a) is important to know. And so because that can be the felon of the lipid neighborhood in certain cases. And so adding an LP(a) to your basic lipid panel, and then really I'm a huge fan of CAC. Okay, CAC's that coronary artery calcium score. In an asymptomatic person with a CAC of 0, if you're 12 years old, getting a CAC isn't going to be useful, but really, in that 40 and up range, and even probably, closer to 35, you have a score of 0 in an asymptomatic person. I mean, you have a greater likelihood of getting mauled by a pack of wolves than having a coronary event, So it's a super good test. Conversely, if you're a young person and you get a CAC and you have a score above 0, you have a 5x risk of a premature event, age 32 to 46 from the Cardia Consortium. And so the power of 0 and the power of not 0 can be very significant. And then if you're 70 years old and you have a CAC of, 0, then it's like, well, God bless you, I'm not real worried about you either there. So, and interpreting CAC based on your age and based on other risk factors is important. That said, there are other bells and whistles. CT angiography, that'll detect soft plaque. And that's, soft plaque is, thought to be more vulnerable. And there are certain people with a CAC of 0 who have soft plaque who end up having an event. But who are those people? Well, they usually they're smokers, they're diabetics, they have high LP(a) and hypertension. And so all these other things that go into our home security system, mainly aside from the lipoprotein(a). And so really, we have to have an understanding of all these things, but And then with the NMRs, I love NMRs. I do talks on how to interpret NMRs. You can really identify insulin resistance even before your fasting insulin goes up. And I talk in my book about, my beautiful example of my wife who, we were able to detect insulin resistance even before fasting insulin rose with an NMR. And so if you understand NMRs, then you can run those. There's a lot to those. And so, and in the remix second edition for the clinician and anyone on a mission for more lipid tuition of my book, which I've written and should be out, I don't know, probably around Christmas or something, because that would be poignant. I explain in detail how to interpret those NMRs if you end up wanting to get the most granular with those things. However, for just adding to what your run-of-the-mill person gets on an annual wellness, add a fasting insulin, and then do a LP(a), know what your LP(a) is. If it's low, you never have to check it again. If it's high, now you know. And then getting a CAC. Got plaque, get a CAC. I want that to become standard of care, to be like the colonoscopy, right? If you go get a colonoscopy and you have a polyp, they don't just leave the polyp in there, wait for you to get colon cancer, and then do something. No, they take it out and check it back at regular intervals, right? So I say, in general, I used to say start at 40. I might say a little sooner now, because the average age of incident CAC was 36 in a recent study in white males, which is a sad commentary, I think, on just how metabolically unhealthy we are more than anything, probably.
Wow.
But really, around, probably 35 to 40, depending on risk factors, right? Here's your first CAC, fire up a 0, check back in 3 to 5 years, depending on risk factors. That's kind of my approach there. And so, treating CAC like the colonoscopy of the heart, such a wonderful test. And if you're having, crushing chest pain radiating down your left arm, well, no, this is not the time to just go and mess around, right? But, in an asymptomatic person just trying to be preventive, CAC is such a wonderful tool. And then just for your lipid panel, yeah, there's ApoB, there's markers of sterile absorption and production and NMR and all these wonderful things that I love because I'm a lipid geek. But really, just from a practical standpoint, just add an LP(a), to your basic lipid panel, and then add a fasting insulin to your CMP. And then, we can really do a lot with that, and I could get all the other stuff, but I can probably pretty much guess what all the fancy stuff will be if I have that information.
Yeah, I love that. When you're making recommendations, you kind of have, you mentioned this before, but like you kind of have a boring way of explaining things, and I kind of do too. Like it's not super fancy to be able to avoid heart attacks and all these things. It's just a few things that you have, and kind of doing them consistently. What are those things for you?
Yeah. So, and this is where people get mad at me because they're like, dang it, that's not what I wanted to hear. I wanted the magic bullet. And so basically sleep, don't eat crap, move, lather, rinse, repeat your whole life, and that's it. That's the answer. And really sleep is such an important pillar, and because one of my favorite studies is they had this group of 20 something year olds, the height of their mitochondrial powers, and they sleep deprived half the group, less than 4 hours a night. And the other group, they just slept as much as they wanted. And after 5 days, the sleep deprived group, half of them had pre-diabetic levels or levels consistent with pre-diabetes on their oral glucose tolerance test. That's crazy. 5 days. I mean, it takes a long time of binging at the Golden Corral and then doing nothing in order to get to pre-diabetes, but it takes less than a week, to get there if you're not sleeping. And so, and that's what's amazing is because sleep is passive, right? Nobody ever said, oh yeah, I'm going to really focus hard, and try to sleep hard. No, you're going to be up all night, you just have to let go. And so if you're not resting and if you're stressed when you are resting, yeah, that's the quickest way to be a metabolic disaster. And so, and that's why sleep apnea is so bad, right? Because, your body's stressed when it should be resting and you have all these catecholamines being released. And, a lot of times when I see people who have uncontrolled blood sugars, despite having the, Josh dietary pattern for diabetes reversal on board, and despite even exercising sometimes, if people still have residually high blood sugars, particularly their fasting blood sugars first thing in the morning, it's probably some due to sleep apnea. And so something to consider there. But sleep's so important. You just got to let go. And that's at the very end of my book. If you get there, I have what's I think a beautiful relationship of metabolic health to spiritual health as far as that metaphor there, as far as the importance of sleep and rest. Otherwise, you're not going to get anywhere. But then, of course, if you prioritize your health, are you going to try to fuel the machine with quality food? And, in general, I say prioritize protein, eat real food. And then, what are you going to do? Also move, because movement is fun. It's such a gift. God gives us minds to learn and he gives us bodies to move. Let's keep doing that. for as long as he keeps us around, and really, you can have a lot of fun in that process, when you keep on keeping on in that regard.
Love it. Well, it's wonderful advice. I love that you keep things very simple and are able to explain all of this stuff. This was an absolute flyby today. There were so many more questions I wanted to ask you about, cholesterol in the brain and yeah, how you wrap up your book. So putting you on the spot, despite the fact that you've lost us Doritos and Golden Corral as potential sponsors of our show, would you be willing to come back and do an entire episode? I don't think one or two questions would really do it justice. So we talk about like cholesterol, fat, and the brain. Would you be
Yeah,
willing to come back on?
I would be honored to, and I agree. It's a complicated topic. There's a lot to it. That's why I had to do a PhD on it, and it would not do it justice to try to do it in about 45 seconds here. So let's do it.
Awesome. Well, that sounds great, Josh. This has been an amazing conversation. Like I said, I love your gift, being able to take these complex topics and break them down in a way that, again, a bum like me could really understand. And so I know our listeners are really going to appreciate your work. And we'll definitely look forward to a second episode where we can go a little bit more in the sticks on some of this stuff. But for now, where can people go to find you and connect with you and your work? And where can people find the book?
Yeah, so my book's just on Amazon. It's called The Home Security System and the Lipid Neighborhood, and you can just find that there. And it's kind of funny, when it first came out, it was #1 in the new releases in the endocrine division, which I joke is like graduating first in your homeschool class. But it actually last week cracked the top 10 in overall bestsellers in the heart disease category, which I feel like that was kind of cool. I don't know if it's still there, but so it's on there. And then I'll probably have the second edition of my book out later this year, next. There's an audiobook too, if you prefer that. And for some reason, Morgan Freeman was otherwise preoccupied, so I ended up narrating my own book because I figured, hey, it was either me or him. And so anyway, but yeah, so that's available for people who want that. And then I am on Instagram. I'm pretty terrible at Instagram, but you can find me there. And I think it's just Wageman Josh at Wageman Josh. And then I'm on LinkedIn if you want to find me there. I'm on X, formerly known as Twitter, at tag Josh J. Wageman. And it looks like Wageman. That E is just kind of a decoy. We get into some really crazy lipid talks on X. And if you just go to my X feed, you might get scared because the real nerds hang out there. But I think more normal conversations occur probably on the gram and LinkedIn. So yeah, you can find me and reach out to me there, as long as you're not a creep.
That's perfect. That's not everybody on social media, by the way. There are going to be some creeps out there for sure. But yeah, we'll link all of that up so it's easy for people to find. So just go down in the show notes. You'll find the link for the book and all of your social media. We'll be sure to link that up. And yeah, for now, Josh, amazing conversation. I really appreciate how much work you put into all of this and translating this in a way that people understand. So thank you so very much for taking time to be on our show today. We'll look forward to doing another one down the road. And yeah, we're just so appreciative of you. So thank you so very much. We appreciate it.
Hey, thanks for having me.
Absolutely. It was such an honor. And this has been another episode of Boundless Body Radio.